So, good morning and thank you for the invitation to present in 10 minutes what can we say about economics of planning and preparing for influenza pandemic and what have we learned in the past 100 years. The first thing that we've really learned the hard way is that influenza pandemics have occurred in the past, and there's nothing on the horizon to suggest that they'll magically go away by themselves. They occur timelines between once every 10 years to up to once every 60 years. And that's problematic. If you go to a policymaker and say, you should do something about it, you should worry about it, and by the way, it could occur in the next 60 years, the eyes of most policymakers glaze over. Next 60 years is way out of their orbit of being worried about for most of them. So it's a hard sell sometimes to say that you have to worry about the next pandemic. Also, when we talk about influenza pandemic, it is clear that it's not a one-size-fits-all in terms of impact. These things vary greatly in who they impact, who gets ill, who goes to the hospital, and who dies. And of course, everybody remembers 1918, but you know what? If you plan solely for 1918, you'll miss what happened in 2009, and you'll be actually underprepared and woefully not ready to address the problem correctly. You have to allow for a great deal of variability. For those of you like numbers and think that economists actually worry about dollars, here are some dollars. There's some estimates from McKibben and Surgan from the Milken Institute regarding estimates of the reduction in global gross domestic product depending upon the severity of the influenza pandemic. And what you get is that pandemics can cause a great economic burden. Even in the short durations, pandemics can come and go in a country within 6 months very often, but they can leave a lasting economic impact that you can feel for years thereafter. And on the right, there's some numbers that we did back in 1999, and KG is a co-guilty member of this. And this is just the impact of not the whole trade in that. This is just the loss of the value of life lost due to lost productivity. And you can see in a 1968 type pandemic, you still get billions of dollars of lost economic impact. Excuse me. Go away. So, what can we do? We have this problem. It's not going to go away, and it's not easy to capture in a simple sentence or two about what is the problem. We have to plan and prepare. We have to have some estimate about who's going to get ill and what's going to happen to them. And we have to have some idea of our interventions. What are they, and how effective are they? And what are we going to do? And it's also clear, and this is true even when I started doing this over 20 years ago, we have to accept that come the next pandemic, unless things change drastically in terms of technologies and things like what are the types of vaccines, there are likely to be shortages, at least initially. And so we have to decide who is going to go up front first. Because if we don't have a plan, we're basically planning for chaos. The plan obviously has to be flexible. In 2009, who knew that people over 65, large portions of them are going to be basically immune or have a degree of immunity? Never planned for that because nobody thought of it. Have to be mobile, have to be flexible. We can try stockpile some stuff, influenza antiviral drugs, mechanical ventilators, but I'm here to tell you, you can't stockpile and buy your way out of it. Stockpiling helps, but it is not the single solution. You have to think about the entire system. This is some estimates that we did. What if a 1968 type scenario type influenza were to hit the US again? First of all, you can't again, as I mentioned, talk about a single number of deaths. There is a range depending on the gross clinical attack rate on the x-axis. That's the percentage of the entire US population that become clinically ill. We're not interested in subclinical illness because they don't burden us with disease and consumption of medical care resources. And the first thing you get out of this is a wide range. And of course, you know which numbers the press at the time emphasized, but in truth, for policymakers, pick any attack rate, and you have to be allowing for a wide range of possible deaths. And the same goes for hospitalizations and cases. You do the economics, look at vaccination by age group and by risk. That isn't the risk of getting the disease. This is risk of bad things happening to you, getting ill, going to the doctor, hospital, death, due to pre-existing conditions such as emphysema and, yes, ladies, pregnancy. And what this says is that, first of all, during a pandemic, virtually every age and risk group, positive returns. In other words, savings by vaccinating those groups, assuming you have the vaccine. But there is a difference by risk group and by age group. And so one of the things that you can do with this is that you can then say, gee, depending upon your criterion, and it is a criterion about deciding who goes to the front of the line first to receive what vaccine is available, particularly at the beginning, how do you prioritize? You can prioritize by, say, risk of death, and these are just examples. I'm sure somebody's going to say, oh, but you could create another column with something else. Yeah, of course you can. You can create thousands, but you get to pick one, not dozens. You can do a mix and match, and what you've done is you've created another column. Or you could do it by dollars to vaccination because you have a limited commodity, a resource, and it's an economics problem. How do you allocate a limited resource so as to maximize return to society that paid for that resource? And there you see in that second column, you put the high risk 20 to 64 years old because they're the ones working and paying taxes and paying for this, and they will hopefully continue working and paying taxes for the recovery. I always ask when I teach this, why is this high risk 0 to 19-year-olds? Kids, second. And you get other people, so you've got teenage kids, what do? They seem to go to high school grumbling, they demand money to buy jeans and video games. What are they? You're paying for the future. They will pay for my Social Security and Medicare, damn it, and I want them alive to do so. You notice, though, if you go by risk of death, in a 1968 type scenario, you have high risk, granny and grandpa, and non-high risk to the top. Which one's best? That's not an economics problem. That is a debate for society. What economics models have done is boiled it down and said, you have to make a decision. You can't waffle. In 2009, what happened is they picked, the ACIP Advisory Committee in the United States, picked between those two and actually ended up with a third option because of the taste, the flavor of 2009. The epidemiology was different from 1968. When stockpiling, what else can you do? Well, stockpiling, you could stockpile mechanical ventilators, but you can't stockpile enough because the limiting factor isn't stockpiles of mechanical ventilators, it's the people to run them. By the way, you're not talking about MDs. MDs and mechanical ventilators equals causing extra death because MDs don't know how to use them. You're talking about the trained staff, such as the respiratory therapists and critical care nurses. They are the ones that are the limiting factors. You have to think of a system. What's the maximum that your system can do, even if you push it to the limits? And everybody says, oh, we'll hire extra nurses. Really? Where do you think in the middle of a countrywide epidemic you're going to find just extra nurses queuing up to handle this? How much has this been planned and prepared? Hospitals, I know at one time were planning. Where are those plans? Have they been updated? Have they been looked at again? Does the person currently in charge of all that respiratory therapy know of those plans? My guess is very often, what plans? Plans? Yeah, plans. Closing schools, non-pharmaceutical interventions. We know that this can work. We also know there's a great deal of limitations. This is a natural experiment in Texas. There were two school districts side by side, closed schools early in 2009. Clearly from this graph, you can see that school closing had a reduction in visits to emergency rooms for influenza-like illness, ILI. Yay. You also notice the moment the schools went back into session, bam, you almost instantly lost any impact. The impact does not carry on very far from when you reopen schools. So if you want an impact on closing schools, you have to do it early before the pandemics really get hold in the community. So your parents will say, why are you closing schools? There's no flu. Nobody in my village or street, none of their kids with flu. Why are you closing schools? I've got to take time off work. And you've also got to close it for a long time if you're going to say we're closing schools until there's enough vaccine. So again, summary, what can we do? We have to plan. We have to allow for uncertainty. A lot of modeling to be done. My experience tells me that this is done best by simple models that you can hand out. We put them on the web. We found a great deal of success in allowing people to download and do their own modeling. We have to have a discussion. We have to have stockpiling, but not just say it's money in the bank, stockpile, and we're done. Have to have plans for that. And we need businesses and communities to buy in, because if they don't buy in, none of the stockpiling and none of the planning will be any good. And I think that's one of the weakest Achilles heels we face, is that a lot of people have forgotten over time, even since 2009, I've got 22 seconds, that we should avail ourselves of plans that have not been exercised or practiced. Thank you.